So, some of you who may have already heard that the Ethics Committee has been working on a project, namely to approach the possibility of ventilator shortage in the event of having too many patients with COVID. And we want to do this in an ethical manner. It would be only under those extreme conditions in which we would require such a policy. The conditions would be horrible, and we're here to ponder and imagine and prepare for what it might be like to have those conditions, as well as having such a policy. Our format today will be for me to introduce the issue of ventilator allocation, as well as an outline of a protocol that we've created. We believe that it is ethically rational, but it is only a work in progress, and one that we will hope we never have to activate. An important part of the perspective we gained in this project is that although this is something that might look good on paper, it will still require much discussion and communication and debate for it to become acceptable. So we consider this presentation today to be the beginning of an important and worthwhile conversation and not the delivery of a finished product. For those of you who don't know me, I'm Dr. David Lee. I retired several years ago from full-time work at Rochester General Hospital, where I was a pulmonary and critical care physician since 1990. I've also been involved with the Ethics Committee for most of that time. And in my partial retirement, I have an interest in how to maintain our humanity when we're taking care of our patients. How can we resist the tendencies in healthcare to make patient care a matter of parts and money? I'll be followed by Dr. Larry Torcello. Dr. Torcello is an associate professor of philosophy at RIT, and he has an interest and background in ethics as well as in social and political philosophy. We need people like him to help us think clearly, and not only from a healthcare provider point of view. Dr. Torcello will be elaborating on some of the ethical issues we deliberated as we tried to develop a policy for the community. I've also invited Doctors Laurie Lerner and Robert Mayo to provide a simulation of a professional interaction around ventilator allocation. Everything we've done so far has been in the realm of theory. We have no real-life experiences to guide our understanding of the consequences of our decisions. So the simulation or role play is an attempt to attach some reality to our deliberations. So let's start. I was not on the front lines in April and May 2020 when COVID first affected Rochester. So I've not experienced the stresses many of you might have had. There were scary numbers of patients. There was incredible fatigue and exhaustion at times. There was worry about the cough that you had or someone that you cared for might have had. And you were worried about whether or not there was enough personal protective equipment. Some of you may even have made out your wills. I also have not experienced the feeling of solidarity that comes from sharing a crisis, that at least you could count on the people you work with. I did not experience the public appreciation that was some compensation for the obligations that everyone met. Everyone showed up every day, as did our colleagues in New York City and now everywhere. And so for those from those who did not share those risks and those costs, we owe you our gratitude, and we thank you very much. I would like to remind us also to add a bit of respect and even awe, that virtues of self-sacrifice and skillfulness and compassion can coexist in real people and inform their actions. This is pretty miraculous. It's also an example of what humanity can be. You are excellent role models, and we thank you again. But now we also owe you preparation. As we breathe fresh air, we have to prepare for the next time that Mother Nature blasts the community with this infection or others. We can prepare to respond with responsible and principled plans so that we do not have to scramble to find solutions in a crisis mode. Let's very briefly review the Rochester experience with COVID to give us an idea of what we might be facing. And first of all, I have to remember that every year our hospitals are stressed by admissions with flu and other wintertime viruses, and we will be adding COVID to that background. How many are hospitalized if they come down with COVID? In the Rochester Regional Health System, so far about a third of patients with positive COVID tests were hospitalized as of this summer. The ratio will fall as COVID testing becomes more available. The Rochester Regional is estimating in the future that about a quarter of patients of positive cases will require hospital admission, and they'll have an average length of stay of about 8 days. And what happens if you are hospitalized with COVID? Of the patients who get hospitalized, about 2/3 will require oxygen therapy, and perhaps remdesivir and steroids and other types of supportive measures. Their average length of stay would be about 6 days. But another third of patients will need ICU care, more severe disease. And most of these will require a ventilator. That's a machine, for those of you not in healthcare, it's a machine to sustain the breathing while the lungs recover. Those patients would need an average of 2 weeks in the hospital. And of those intubated, about a quarter of those intubated will die despite all the technology that we give them. This is much better, however, than the estimated 80 or 90% mortality reported at one time from Wuhan and New York City. So overall, therefore, if you contract COVID in Monroe County, you would have about a 1 in 4 chance of needing hospitalization. And once hospitalized, there's a 2/3 chance you could leave in a week and a 1/3 chance you will struggle for 2 weeks, including an ICU stay. And about 5% of all COVID positive patients in Monroe County might or will die of their illness. But fortunately, it is unlikely that we will run out of ventilators at least this year, based on our current projections. Rochester Regional can mobilize up to 200 ventilators, and the Strong Memorial System about 400. And at the peak of the COVID surge, around May 22nd, Monroe County had about 1,100 active cases, an average of 70 new cases a day, and 171 patients in the hospital, of which about 60% were in the Rochester Regional hospitals. Currently, we have an average, and there were about 21 COVID patients on ventilators. Currently, Monroe County is maintaining a daily average of about 21 new cases per day. And the Rochester Regional inpatient census was 14 or 15 in the last week, although 2 weeks before that, it was only 7 cases in all the Rochester Regional hospitals. So if there's a projected second wave, the projection is that there will be at most about 150 or 250 patients hospitalized with flu and COVID. And the alarms, this is clearly lower than the limit of 200 that we have on the limit that we have with 200 ventilators available. The alarms will start going out when there are about 40 or 60 patients in the hospital with COVID, and that would be about a rate of 50 per day in Monroe County and 8 per day with new admissions to Rochester Regional Hospitals. So to COVID, we're all meat, and if we don't limit its spread, So these models are reassuring, and we hope that they predict the future accurately. It gives us time to improve our plans for a worst case scenario. I'd like to illustrate, and I think we would all like to imagine that this worst case scenario that can be avoided if we keep the numbers down. And we don't want ever to be in a situation where we wish we could have done better. As someone has said, to COVID virus, we're all meat. If we don't limit its spread and prevent spikes, then we might be forced to accept the need to use a protocol and a committee to make these life and death decisions for us, as we'll outline. So what might it be like without a COVID ventilator allocation policy? So let's imagine that we have a week before Christmas this year, where the pandemic has accelerated amazingly in the past month. The MICU and 5,400 and 4,200 are full of pulmonary patients, and 3 additional ICUs might have opened to accept COVID patients. So the surgical intensive care and CTICU and PACU also. There will be a total of 125 patients on ventilators using anesthesia machines as well as ventilators given by New York State. And now with only 1 ventilator left, they're in the emergency department without any policy for allocation. There's a 65-year-old woman without any significant medical history, but she's hypoxic and confused, and she has infiltrates consistent with COVID. There also is in the ED a 50-year-old man, patient B with a renal transplant who is hypoxic and also might need intubation. How do you decide? How does one decide if you have no policies in place? There have been stories about ad hoc decision-making in Italy and in Texas and in the Bronx. We don't know about those details, but the specter of having to make such decisions on your own is very frightening and disheartening to practitioners. We believe we don't want cowboys to make the decisions, and we don't want individuals to bear the ethical and legal brunt of their decision-making. So there are articles, many articles suggesting how to write up policies. Our policy that we're sharing today is, I think, one of the first that could be shared publicly. Policies should have principles and responsibilities. They would articulate ethical standards of care, and once in place, it could be a basis for limiting legal liabilities. So having a policy seems like a good idea. On the other hand, policies can also hide the arrogance and the hubris of institutions. This fictitious statement is clearly outrageous if it's used to justify an individual's ad hoc decisions. In a movie, a chief of surgery explained to an intern that our society faces momentous decisions about terminal illness, prolonged coma, transplantation, decisions about life and death. But society isn't deciding. Congress isn't deciding. The courts aren't deciding. Religion isn't deciding. Why? Because society is leaving it up to us, the experts, the doctors. So this fictitious statement is clearly outrageous. There's no consideration of one's hidden biases or appeal to shared ethical principles. It's the stuff of movies with doctors as the villains. My question is this, and the challenge also, that even if biases and rational principles are considered, even if society is leaving it up to us, the experts, does having a rational policy mean that the policy is also ethically sufficient? Our objectives today are fourfold. And we're going to describe the four principal steps in the ventilator allocation process. They are, first of all, using the so-called SOFA score, the Sequential Organ Failure Assessment, to assess the patient's risk of dying despite the best care that they could receive. And then the second step would be to take those SOFA scores to a ventilator allocation committee to prioritize which patients would need a ventilator, would be eligible for a ventilator, and which would be eligible to lose a ventilator. Then there follows a need to communicate with the care team as well as communicate with the patients and the family. We were going to identify the competing priorities that would be ethically problematic today. How do patient interests get balanced against the fair distribution of resources that are scarce? And then later, we hope that we'll have some time to reflect on the personal challenges as well as the practical challenges that you would have if you have an allocation process that is involuntary. And once we've discussed those challenges and identified them, we also have to think how we can get through them, how there could be personal as well as institutional actions to prevent or mitigate the burdens of a process like this. As we hear about the policy today, let's think about these questions. First, we realize there would be problems if we did not have any policy to prepare for a ventilator shortage. But today we also, I think, will find out that we will have problems. What do we do about the problems if we actually did have a policy that we needed to apply? And second, the second type of question is that if we accept that in the end we have to allocate ventilators, what do citizens and what do decision makers have to do long before the end actually arrives? What kinds of responsibilities before then do we have to each other if we wish to have a community with a shared common interests? I do believe that our policy might be the best that could be devised in accordance with the principles that we followed. But for it to be acceptable, the public also has to accept and acknowledge it and find it trustworthy. Today is the first of many steps in the building of trust. So I want this to be an opening of some difficult conversations about how this healthcare system has tried to be responsible and responsive to its many constituents. As we discussed how to triage ventilators if they should become scarce, we had the benefit of a template. In 2015, New York State proposed guidelines for approaching this dilemma if there was a pandemic influenza outbreak. It was the result of experiences with a crisis in 2009 when there was an H1N1 influenza outbreak, and also fears from the 2003 SARS outbreak in Hong Kong and Toronto. Having these guidelines has helped us by allowing us to use a template as a management issue. We could sort of check off the boxes that the state proposed. And a large handful of us have worked on this problem for the last 6 months. There's been a committee to devise a protocol. It's been multidisciplinary and very collaborative. It has not been a group of physicians only, and it's included many health-related disciplines as well as input from community-based organizations and ethics advisors. And the primary goal of is outlined by the New York State guidelines as well as this policy is to save as many lives as possible in the near term. The goal is simple and difficult to disagree with, but as we'll see, there have been significant ethical challenges raised to the premise that only short-term mortality should be considered in making triage decisions. We had lively debates on other considerations as well, and Dr. Torcello will describe some of those issues. The New York State guidelines also recommended that objective criteria be used to determine prognosis in order to remove as much as possible the subjective and unconscious biases that we might have. Their suggested basis for objective decision-making would be the SOFA scoring, which we'll describe in a moment. Higher and rising scores in SOFA would imply worsening organ failures and thus mortality. And priority for ventilators would be based primarily on SOFA scores. And the data being considered should be scrubbed and have as much demographic and clinical data removed as possible. The SOFA scores are then sent to a ventilator allocation committee to make a decision. And the ventilator triage is based on the SOFA scores. A committee was used or recommended to make decisions as objectively as possible, as well as to minimize moral distress to individuals that might be making such decisions. So let's describe SOFA scoring and so-called color coding. SOFA scoring, the sequential organ failure assessment, was a mechanism devised more than 25 years ago to help with clinical research in intensive care units. It uses quickly available data in 6 organ systems to generate a composite score. Patients would have 0 to 4 points for each parameter, and the maximum score would be 24, 4 points in all systems. A score of 11 or 12 generally correlates with a better than 50% mortality. So it's a relatively quick and consistent scoring system. It doesn't rely on expensive and proprietary algorithms, and it does make some clinical sense. There are limitations, there are many limitations as we found with its application and even its conception, but actually and practically there are no better systems available right now. So using the SOFA scores, the Ventilator Allocation Committee would then classify patients by color coding. Purple patients would have physiologically futile outcomes, and they would not even be eligible to start a ventilator. Red patients, red is good in this situation. Red patients have low scores, not much organ failure, and thus have the best prognosis and the highest priority for ventilator use. The blue patients are the worst ones. So they have either high scores, more than 11, or else their SOFA scores are increasing. They would have the lowest priority for patients. But as a matter of fact, even in our ICUs at this point, we have patients in the blue category with scores above 11. Their odds are poor, but they're not 0. And then yellow patients would have prognoses between red and blue. Finally, in the likelihood that there would be many blue patients at one time, there has to be a way to prioritize among the blue patients. And so a lottery will be performed to list the order in which patients might lose their ventilators. Patients who are thus mandated to lose their ventilators could be expected to die as a result. They still would have to have their comfort maintained and their families supported. This framework, of course, has never been put to the test, and because we've never faced a shortage. It may have to change once there are real experiences. It is a system that asks the community to trust that we, the experts, have done as good a job as possible, even though perfection is not possible. So now I'm going to turn to Dr. Torcello for more details on the ethical issues we confronted when drafting this proposal.
How should one think about ethics? At minimum, ethics is concerned with justifying one's behavior in a way consistent with reasoned argument. To bother with justification at all is to recognize implicitly that others are morally important enough that your behaviors toward them ought to be justifiable. The principle-based approach advocated by philosophers Tom Beauchamp and James Childress has become the standard in clinical ethics. These principles involve the principle of autonomy, non-maleficence, beneficence, and justice. Principle of autonomy. This principle emphasizes a patient's role, assuming decision-making capacity, as primary decision maker regarding their own health. It requires healthcare practitioners to defer to a patient's wishes, even if those wishes seem misguided from the healthcare practitioner's point of view. Principle of non-maleficence. This principle emphasizes a healthcare provider's obligation to avoid exposing a patient to unnecessary harm in the course of treatment. Principle of beneficence. This principle emphasizes the duty of a healthcare practitioner to advocate in the patient's best interests. And the principle of justice. The principle of justice advocates equality of care with respect to patients' different interests. In practice, the principle of justice is complicated by scarce healthcare resources. While these principles can be defended philosophically within frameworks of traditional ethical theory, deontology, utilitarianism, virtue ethics, etc., they have a self-evident appeal for most people. They are simple enough to find consensus across an array of different value systems while serving as practical points of reference in clinical situations. While all of these principles warrant consideration, the principle of autonomy has emerged as a regulative principle guiding the standards of ethical care. One clear reason is that we all have our own biases. In focusing on a patient's interest in making informed healthcare decisions, healthcare providers will better keep their own interests and biases in check. The patient is best positioned to make decisions in the context of their own life circumstances and values. The question during a crisis like the one we're contemplating is how to honor ethical principles. While there are not enough resources to give every patient the normal standard of care they deserve. The moral tragedy is that the best decision available still involves intrinsic loss. Healthcare providers are asked to make decisions, and community members are asked to make sacrifices that under ordinary circumstances would seem and would be morally irredeemable. It is difficult to prioritize a patient's autonomy under conditions of ventilator scarcity. The priority is minimizing harm across the community as a whole. The best we can do to honor autonomy under such circumstances is to make sure the community is fully informed of the situation they face. Avoiding the situation requires being forewarned of the high stakes implicit in the need to continue social vigilance against viral spread. The most defensible ethical path forward, given the scenario we hope to avoid, is the ethics also endorsed by New York State. To save the most lives possible, by basing ventilator allocations on clinical prognosis. This means making difficult decisions grounded in clinical factors alone about which patients are most likely to survive and recover on a ventilator. In this sense, ventilator trials are initiated with a strategy geared toward maximizing life-saving effectiveness. We considered other possibilities, but could not ultimately justify them as standards for ventilator allocation. These possibilities were first come, first serve, quality of life, life stages lived, life years, prioritizing healthcare workers, and the correction of inequalities. First come, first serve. This is effectively hoping for the best while not having a plan. It favors those who are more informed, more financially secure, and more likely to present at a hospital earlier. It would likely exacerbate social inequalities already playing out during the pandemic. Quality of life. This strategy involves making subjective, clinically irrelevant determinations about a patient's quality of life and the benefits of prolonging that life. No one is qualified to make such determinations independently of a patient's own assessment. This strategy would potentially place an undue burden on the disabled. Life stages lived. This strategy attempts to give preference to those who have not yet lived out particular stages of life, and therefore increase their likelihood of living out those stages. The problem is that such judgments are inevitably subjective and based on a homogeneous view of what a life fully lived normally involves and what stage one should be at in their lives. Life years. This allocation strategy involves prioritizing a patient based upon the patient's age. This too is overly subjective and brings in many of the same biases as the life stage strategy. The detail of a patient's life and the impacts of a patient's death on their community cannot be reduced to age. Moreover, it is not always the case that a younger patient will have a better chance of survival than an older patient. This allocation strategy is straightforwardly ageist. Prioritizing healthcare workers. On its surface, this strategy seems consistent with saving the most lives. If healthcare workers are prioritized, then they may be able to get back to work saving lives and helping the broader community. The primary difficulty with this is determining who counts as a healthcare worker essential enough to be prioritized. By this logic, should we be prioritizing delivery workers, teachers, and grocery store clerks as well? The reality is that during a global pandemic, the list of essential workers extends far beyond healthcare professionals, as important as you are. And addressing inequalities. It is well documented that COVID-19 is disproportionately impacting communities that suffer from systemic racial inequalities associated with an increased rate of comorbidities. Sadly, if we were to attempt to account for such inequalities by prioritizing vulnerable communities, those systemic inequalities would continue to exist, while more lives would be lost throughout the community. It is crucial to correct systemic inequalities in society. It is not possible to do so by means of ventilator triage. Systemic injustices must be addressed with systemic reforms. The moral tragedy of ventilator allocation. The strategy of saving the most lives by factoring in probable clinical outcomes is the least likely to stack additional biases against already vulnerable members of the community. The moral tragedy derives from the fact that there is no choice to be made during ventilator crises. That is good. The best we can do is mitigate loss and suffering by attempting to maximize lives saved. It remains the case that lives will be lost that otherwise would have been saved. There is no good solution other than avoiding these circumstances altogether. Thank you.
Thank you, Dr. Torcello. Yeah, it's tough. It's very tough, and I think that to add to, as you said, there is no way to get through this thing easily, and without loss and difficulty for all involved. So I think we're going to ask Dr. Lerner and Dr. Mayo now to play out a hypothetical scenario of ventilator allocation. I'm going to share my screen and then turn it back to them, but first for a few moments. Let's begin. Sorry. So we begin again with the same scenario as before, but now with an allocation policy. We still have the week before Christmas with the COVID and flu epidemic accelerating. The hospital is still full with pulmonary patients everywhere, as well as in ICUs that were not meant originally to take care of medical patients. There's a total of 125 patients on ventilators. There's only one clean ventilator left. And in the emergency department, we have patient A, who's a lady with COVID-type disease and needs a ventilator, as well as another 50-year-old man with a renal transplant who's hypoxic, and he also needs a ventilator shortly. So with an allocation policy, we have additional information. In the MICU, there are patients on ventilators with COVID in various phases of their illnesses. They've had their SOFA scores calculated regularly with information available in Care Connect. So patient C is a hypothetical patient. This is a patient who's a 55-year-old woman with moderate emphysema, and she came down with flu 9 days. It was admitted 9 days ago with flu, and she also developed pneumonia and complications, leading to acute renal failure such that she has to be on dialysis now. And unfortunately, overnight, she develops new pneumonia on a ventilator, giving her hypoxia, infiltrates, and low blood pressure. Patient D is another patient in our ICU with COVID pneumonia and complications of that. He had a stroke and mild renal failure, but is not on dialysis. He's now on day 15 of hospitalization. He had to be trached 2 days ago because he's having weaning trials, but he's no longer, still requires a ventilator for support, but he's getting better. So SOFA scoring has been done. And in this morning, the Ventilator Allocation Committee has now met and is trying to identify which patients would be at risk for losing their ventilators. The VAC has coded these 4 patients as follows. Patient A has a SOFA score of 6 and therefore she is in a red category and was eligible to get a ventilator. Patient B in the emergency department also has a SOFA score of 6 and he's eligible to get a ventilator. Patient C had a SOFA score of 6 yesterday, but today she is 9 because of her new pneumonia. So she now is categorized as a blue patient because she has been in the hospital 9 days and is getting worse. Patient D on day 15 has a SOFA score of 6 and his score has not changed in several days. His category becomes yellow because even though he has a SOFA score of 6, he's been in the hospital 15 days with a failure to improve. And so his prognosis is deemed to be intermediate between red and blue. There are many patients with blue category. And so there's a lottery that's performed and patient C is identified as the first patient among all the other blue patients who should lose for ventilator. So now the Incident Command Center that has been busy this last couple months asked the administrator on call to call the MICU attending as well as to inform the family. So Dr. Mayo and Dr. Lerner will play out this scenario.
Hi, Dr. Lerner. It's Dr. Rob Mayo calling.
Hi, how are you?
Oh, I'm doing all right, thanks. I know it's been really tough lately. How are you doing in the ICU there?
We're hanging in there, thanks.
Yeah, I rounded there yesterday afternoon, and I know it's been really tough on the team, and really appreciate all the hard work you and the others are doing.
Thanks.
You'll recall that we participated in developing the ventilator allocation process, and we are now facing this reality. So I wanted to talk with you about that because the Ventilator Allocation Committee met this morning and scored a number of patients both in the ICU and in the ED. Patient C, who you are taking care of, has had an increase in her score from 6 to 9, which places her in the blue category. As you know, we then performed the blue category allocation, and she is identified to be removed from the ventilator.
Mrs. C?
Yeah, this is patient C.
You sure? I don't know. You know, she's doing pretty well. You guys have your numbers right?
Well, let's just talk about the clinical setting to be sure that we do. But, you know, we reviewed the chart carefully. We saw that she has a new pneumonia and worsening hypoxia.
Oh, so
20
she's
hours.
getting scored blue because she's gotten worse. Well, you know, so she's just, you know, she's on dialysis. I get that. But, you know, she started making urine today. And, you know, these infiltrates and her oxygen requirements, I mean, I think maybe it's some of its volume. You know, I've been talking to nephrology. We're going to increase the ultrafiltrate. And I know we already did that. And she went on a little bit of pressors just to accommodate getting more fluid off. But I see a clear pathway to recovery for this lady. Do I have any, can we ask for a review?
Well, the Ventilator Allocation Committee does do a very careful job of these reviews initially. There's always room to reconsider, but as you know, we have 2 patients who are in the ED who are in need of an urgent ventilator. And delaying this decision could place their lives in peril as well.
This just feels not right. I mean, she's a single mom. She's got a 13-year-old, a 16-year-old at home. She's still working. This is a high-functioning individual. And I can save her. That's crazy, Dr. Mayo. This is not working out right.
You know, I really feel the pain of this. I think we all knew that one day this could be possible. But I really think it is important that we stay aligned with the policy that was approved so that we can maximize the saving of lives across our community.
So who's going to tell our kiddos?
Well, let's talk about that. I think it's important for us to be really supportive and to find the best path forward with this. Do you know, does she have any close siblings that her children would view as aunts and uncles that are mentors or close in their lives?
I don't know.
All right.
Things have been
guys.
so crazy here. I guess I don't know her as well as I should.
All right, guys, thanks so much. That's I kind of wrote that vignette to make it help us realize that these things when we're dealing with a policy, we're dealing with populations. When we're dealing at the bedside, we're dealing with people. So I think that that is just one of the possible difficulties with trying to put a policy into place. I think we can imagine many other difficulties. We've already introduced how do you communicate this harsh fact to the patient's families. We also have how do you explain all this? How does Dr. Lerner explain to her team? How does the respiratory therapist and the nurse taking care of the patient have to deal with the heartache of watching a patient they have taken care of for a week and a half, and who they think really under ordinary circumstances might get better. So I think that what we need to do at this point, because a policy, if you're really ran out of ventilators, we're going to be stuck with these scenarios. And so let's discuss about what are the personal and practical challenges that we have? How do we try to mitigate some of the consequences of those, the fact that the policy even exists? How do we mitigate the burdens of the effects of those policies? We've done a very good job rationalizing and producing a reasonable policy. And I think that one of the points that I have is that a reasonable policy is necessary, but it may not be sufficient for it to be ethical. And a mutual trust and responsibility are present. Unless that mutual trust and responsibility are present, there is a danger that only those with power will feel that the policy is ethical and just. So how do we make a policy more trustworthy? What do we do with preparing Dr. Mayo and Dr. Lerner for this possibility? And how do we make it trustworthy to our colleagues in healthcare? How do we make it more bearable for patients? And how do we inform the Rochester community? And I don't know if they're good, if we're going to have a policy, we have to try to deal with all of those questions. And if there's a policy, if this policy is an attempt to manage a nightmare, that's the point that Dr. Torcello brought up, that maybe we have to avoid the nightmare in the first place. So we have time for questions and comments. I think that I'm going to stop my screen sharing. If participants have questions, please drop a chat and and we'll read those out to the rest of us. Dr. Reynolds thought that was an amazing dialogue, you guys. Laurie, you put Dr. Mayo on the line, and Dr. Mayo, it looks good on paper. But it is not so easy when we have to deal with patients. Laurie, did you think that this was a realistic enough situation?
I did, and I was surprised that it actually invoked a pretty emotional response for me. I think that it's probably very plausible that we could be in a situation like that. And honestly, I was thinking in my mind, I think I would refuse. But I don't know how that would play out.
We have a bunch of people's microphones going.
Everyone who are getting interviews, I hope the best for all of us, including you who's applying. So let's see how the season comes for all of us.
So I guess I want to reflect a little on Laurie's comment that that in the moment, in the heat of it, she might feel the inclination to refuse, and how we as healthcare providers would deal with that. I think from my perspective, having done a lot of the work with the Ventilator Allocation Committee, the Ventilator Allocation Committee, at least theoretically, has potential for broader system awareness to get through that, as David has described, fog of war idea. Whereas each of us, when we're operating as bedside clinicians, have our duty to the individual patient, and Dr. Lerner's inclination to refuse to go along with the Ventilator Allocation Committee is absolutely consistent with the ordinary ethics that all of us clinicians bring to the bedside. And the purpose of the Ventilator Allocation Committee is to perhaps give us a broader social justice view, recognizing that really tears at the fabric that exists in the patient-provider relationship.
Mm-hmm. And pressing forward as in this role as an administrator feels painful too, right? Because you recognize the moral crisis for the team and the family, and this is something none of us have ever done before in any roles that we are in. And it's so the inclination for the administrator to back off based on the emotions of the team and the situation is also a significant challenge to overcome. And it certainly can undermine the value of the entire process.
No, it's, we obviously are facing an issue where everybody loses choice and agency. You have lost it as the administrator. Laurie has lost it as a doc. The patient has lost agency. So I suppose one of the questions is, you know, do we explain to the community, the hospital community, the patient community, the Rochester community, that this has, you know, there could be circumstances in which you lose choice. And then, you know, and then everyone says that, well, all right, it's, you throw up your hands and then you say, well, the protocol determines and we accept that. We no longer have a responsibility to my patient because this is overruled by the protocol. You no longer have a role or responsibility to problem solve with this because you just acquiesce to the policy. That's kind of what we're saying here, and it's pretty gross.
So John has a question, and I think this one is for Dr. Lerner, since you sat on this part of the committee. Do you have advice if a patient's family asks about 2 patients on a single ventilator and or short-term manual bag valve ventilation?
Right. So as a part of the ethics committee, and Dr. Reynolds, jump in here and help me with kind of the framework, how we discussed this. But we struggled quite a bit with where in our policy would these adjunct or unproven or maybe less desirable ventilator strategies fit. And so including is this idea of ventilator sharing, as well as bagging a patient, or there's also some use of non-invasive ventilators adapted for invasive ventilation, or possibly use of less desirable critical care ventilators. So there's kind of this grab bag of less than optimal ventilators. And we looked at a couple of different frameworks. One would be a lottery, whether folk would go towards one pathway or another, or doing a strategy of first utilizing all the ventilators, the optimal critical care ventilators available, and then if someone was allocated to remove a ventilator, then offering these secondary devices. As a group, we thought it was most appropriate to put these alternative ventilator strategies after ventilator allocation.
So I think that we proposed that a bag, well, we actually did not want to, we did not think on paper that having a family or someone do the ventilation by hand would be a good option, I believe. It's both dangerous as well as now, you know, it now again places a burden back on individuals for the life of this particular person.
The New York State guidelines specifically talk about the potential role for family members or loved ones to bag valve ventilate a patient. As a practical matter, two I think important points came out of that. The first is that it's physically impossible to do it for an appreciable long period of time, just that a family member would fatigue. And then secondarily, it's clearly a less ideal or less adequate mode of ventilation. And given the fact that it's unlikely to be an adequate long-term strategy, at least for, you can't do that for several days while somebody's getting better. The emotional burden that would put on a family member who would want to keep going but physically just could not, and then have the patient die as a result of inadequate ventilation with the family member bagging at the bedside would be too steep or too burdensome an emotional weight to put on that loving family member, to the point where the New York State guidelines recommend against allowing family members to do that, to take that strategy.
I think that one of the other things that came to my mind, and a lot of things come to my mind, but among the things that we would have to put into place would be the understanding in the ICU, as well as almost on admission, that everything we do in the hospital in a pandemic, as we approach a crisis, is a kind of what we'll call a therapeutic trial. Every day is a new day. And patients need to, families and staff need to be well aware of the fact that a patient who, under ordinary circumstances, might not do what we would try very hard for very long, that there is the possibility. We have to let people know ahead of time that there's a possibility that they might have to face this possibility. And I don't think we can wait until there's a pandemic to start that conversation, that everything is possibly limited. It goes against everything that we're used to. So that is one thing. If we're going to put this thing out to the community, we also have to let everyone know that when they come into the hospital, that nothing is given, and somehow the rest of us are working in good faith to try to give them the best chance, but it is not a guarantee. Do you think that would have helped Rob and Laurie if that conversation had gone on?
I do feel that education and dialogue around this and other difficult topics is a healthy and good thing to do. This type of scenario, takes months to digest and to really think through. So I'm not suggesting that a brief conversation at admission is enough, but it's something, and I think that the more we can address it, the healthier the dialogue can become.
Rob?
David, from a practical point of view, all of this emotion and struggle is occurring in a very time-constrained setting. So you don't have a lot of time. And mostly we don't learn critical procedures in a first time you have to do it. You have to do it in real time. And this is all about relationships and the quality of the conversation by the time it arrives at the foot of the family or with the family is going to be determined by the quality of the conversations and the feelings and how they were managed in each sequential conversation preceding the one with the family. So it's almost like you need to do repeated simulations, not just with the scoring and the allocation, but the conversations. And the conversations need to happen with multiple people who would be the ones to be having the conversations, so that these kinds of problems and how you navigate the conversations get worked out before you actually might have to do them.
There's a last question. How do we balance the duty to share this protocol with the community with the duty to avoid unnecessary community panic? What's the right way to share this with the community without eliciting undue stress?
Larry, you wanted to take that one?
Yeah, certainly it's a concern. I think that by, again, beginning this conversation earlier and allowing the community to have time to digest it, that's going to go a long way. And one of the other things you have to balance here is knowing that this could potentially cause a lot of stress in the community. accompanying the message with very clear messaging on how to avoid this in terms of continuing to social distance, to wear masks, to do all the right things to keep the community safe. That's perhaps one of the biggest benefits of including the community in this conversation, because the community has a role in avoiding this. We all have a role in avoiding this together. And so I think that has to be the primary point in communication, is empowering the community to avoid this scenario with us.
And I think that Larry and I, in talking about this, I think, I think that we all have the appropriate feeling. Boy, it looks great on paper, but we have to do everything we can to flatten the curve, avoid overwhelming the number of ventilators, the 600 in the community, the 200 in Rochester Regional Health. And that's not, and Rob, you and the administration needs to have the option of, you have to, as it gets closer, you have to keep raising the number of ventilators that we can have. It won't be this year, but it might be some other year. But in the meantime, it's going to take a lot of time, as everyone has said, to get people used to the idea that we have to lose freedoms in order to, in order to make the community healthier, or to keep the community healthier. And I guess I'm not sure that panicking the community is my biggest worry. A little bit of anxiety is a little bit of challenge, I think, can be motivating. But ultimately, I think that the challenge is, in a crisis, do we pull together or do we pull apart? And that's kind of the message we have some time to address now.